My name is Elisabeth Widén. I'm a researcher at the Institute for Molecular Medicine, Finland. I'm a medical doctor by training, and our main focus of the research projects, here at our institute are common complex disease and the genetic impact on the disease risk, with reference now to common complex disease. And breast cancer obviously is a common disease which has a genetic background that is in part is complex as well.
Michael Inouye, I'm a computational biologist and director of research here at the University of Cambridge, and also Mun's Chair of Cardiovascular Prediction and Prevention at the Baker Heart and Diabetes Institute.
Regarding the polygenic risk, it is a type of disease risk information that currently hasn't been used in clinical practice. It's rather new, and there are two ways by which we can think of immediately or in the short term in using the polygenic risk information. One has to do, and that has to do with the risk that healthy relatives of breast cancer patients have. What is the risk for breast cancer? And that is in part mediated by these rare mutations and in part mediated by the polygenic risk. So breast cancer patients who have a very high polygenic risk for breast cancer, their first degree healthy relatives are likely to be at elevated risk as well. And by measuring the polygenic risk, we can now identify individuals at high risk that has not been identified before. And the other way we can use polygenic risk information is to assess, with more or more specifically the risk of a mutation carrier. So, not everyone has the same risk, that the mutation and the polygenic risk, work together and define the overall risk for the patient. The research that has been conducted over the past 10 to 15 years has shown a similar pattern across the spectrum of common diseases, that there is this genetic component that is built based on single variants who have a very small effect on the disease risk on their own, but because there are thousands of them or millions of them who impact on the disease risk, their combined risk is considerable. And this applies to many diseases. And now, even though the genetic background is similar across all these diseases, it's going to be disease specific, how you can best utilize this disease information. So with respect to cardiovascular disease, for example, we can get a better estimate of the disease risk by combining the information, from the genome with clinical risk factors. And that is a use case that is specific for cardiovascular disease, because there are already disease risk calculators that are based on clinical factors used in the clinic. And what we can do with the polygenic risk information is add to that information to get a better disease risk estimate. With respect to breast cancer, I can see or foresee that, with the polygenic disease risk information, we can identify individuals at elevated genetic risk that have not been identified before, because we have not had any tools, to address this. We know that around 20% of the women who get breast cancer have a very high polygenic risk. And so when we do cascade screening and assess their first-degree relatives for elevated risk, we can now extend the screening to the relatives of the women who are at high polygenic risk. And we don't have to look at women with single mutations alone.
In terms of early detection of disease, or at least detection of disease before it gets too bad, the use of PRSs, particularly for autoimmune diseases, has showed promise in increasing the efficiency of diagnoses. Again, in use with other clinical tools, whether it's MRIs, whether it's autoantibody levels, that sort of thing. So there are various studies, particularly in type 1 diabetes or ankylosing spondylitis, or even celiac disease, which have shown promise in that area, in improving and refining diagnoses. And perhaps the other one that's worth mentioning is also how we increase the efficiency of preventative medications. So, this is still very much in a research phase, but various use cases with potential clinical utility have cropped up for polygenic scores.
The genetic studies provide a different angle. It's kind of an agnostic view to detect new disease mechanisms. So I do think that particularly in terms of diseases where we don't have any efficient treatment available, the genetic studies can make a big impact, shedding new lights on the underlying biology, to help the development of novel treatment for these diseases that we cannot treat efficiently. So that's a different way of utilizing the research information. And obviously it's a path that is, more long-term. It takes time to understand biology, and it takes time to take that information and develop that into new therapies. But there, I think that the polygenic risk information really can bring new and important information to the table, to help develop new therapies. Then the second part of the question, what do you do with that information if you can identify individuals at elevated risk for a disease that cannot be cured or that cannot be treated? Then I think we are in the same territory as we are with diseases that are caused by single mutations that segregate in families.
The answer to that is that the score itself is very, very stable. That is, it doesn't change or may change very minutely throughout the lifetime of the individual. And that's because it's due to the germline genome, as opposed to what we call the somatic genome. So the score you get from a polygenic score is essentially the same one that you would get at birth, if you were to try to calculate it then, as you would if you lived to your 90. From a pure technical point of view, it doesn't really matter. Mm-hmm. But obviously the timing of when you might sequence someone's genome, run their DNA in an array, calculate polygenic scores is a much bigger question than just a technical question. The technical part is relatively simple. Clearly there's all sorts of factors, which I'm not sure you're sort of asking about, right? When it comes to consent and when people might be best sort of in the right frame of mind or in the right sort of life stage where they're able to assimilate and act, understand, assimilate, and act on the information, the genetic information given to them. It's a much bigger question. I don't think we know the answer to that. It's certainly a difficult question. It's one that's very much in the research arena.
I think that, the handling of genetic information should be as responsible and regulated in the same way as health information is in general, because there are many different ways, unfortunately, to discriminate against persons, and it's clear that health information in general is sensitive information that should be handled with care.
It's not like other clinical tests which have that level of discriminatory power, right, in a clinical sense. What we're talking about here is risk. We're talking about probability, and we're talking about it in the sense of, and I use the same analogy again, of the how one might think about how they have high blood pressure, right? Generally, Joe walking along the street generally knows that having a high blood pressure is bad for them, and that it could it could sort of result in them having a heart attack or something like that. But they know that all those instances where they get really angry, or they get, they're under high stress, right, and they have elevated blood pressure, that doesn't mean that in that instant they're going to have a heart attack. It means that, sustained, high stress, that sort of thing, that there's an elevated chance of something happening. The paper that was published in Nature Medicine is from the International Common Disease Alliance Polygenic Risk Score Task Force, and that's a separate thing than Intervene. So the task force is comprised of not just sort of there's a bunch of polygenic score experts on there when it comes to the analysis, when it comes to the genetics, et cetera, but there's a much broader expertise when it comes to like ethics and regulatory issues and behavioral science, risk communication, et cetera. So it's a very interdisciplinary body, very, very international, not just European. And some of the Intervene investigators are on the ICDA, the Polygenic Risk Score Task Force. So Intervene, as we all know, right, is a Horizon-funded EU project, and there's many excellent people on that consortium. So Intervene focuses on some of the key sort of gaps that the PRS task force has identified. So, for example, and this isn't comprehensive, but the development of polygenic scores when it comes to maximizing their potential utility, that is maximizing, say, for example, their predictive power, maximizing their generalizability across various sort of demographics, for example, ancestries in Europe. And that comes from having many different biobanks, part of the Intervene consortium. And also there's an infrastructural angle as well. So, for example, developing a polygenic risk score platform whereby PRSs can be calculated and sort of put within an appropriate risk communication framework, all the way through to how it facilitates research activities that, like, for example, competitions amongst research groups to develop more equitable, more powerful polygenic scores, all the way through to the ethics and the risk communication side, and even running trials. So Intervene really covers a broad swath of a lot of the gaps that the Polygenic Risk Score Task Force paper identified.
The polygenic risk scores, what we also do, for example, in the breast cancer pilot study, is then to test practical procedures for how the polygenic risk information could be implemented in the clinical environment. So as Mike says, the Intervene spans, a very broad spectrum of activities, related to, polygenic risk scores and their future implementation in the clinic.
The Nature Medicine paper was intended to relatively comprehensively cover the gaps. There were some that weren't quite as prominent, which I think Intervene focuses quite well on. So one, as I mentioned, is polygenic risk score infrastructure, that is platforms. Intervene really has a strong focus on that. And that really comes down to connecting the knowledge information that comes out of research with practical implementations and ensuring that that you have the tools at your disposal and those tools talk to each other.